I'm Jeff Garland, United States Attorney for the Southern District of New York. On October 22nd, law enforcement recovered the first device from a resident of George Soros. Over the last 5 days, as more packages were found across the country delivered to former presidents, our law enforcement community, federal, state, and local, has worked day and night to get up.
Hi, everyone. So sorry about the technical difficulties there. This is Lindsay Bourne, now Lindsay Galley. I'm the Director of Education here at PSCC Partners, and I'm actually in the Long Beach office with the rest of our team for our staff days. I am joined by PSCC Partners founder and CEO, Libby Boyd.
Good afternoon, everybody. Thanks for your patience with our little bit of technical difficulty.
Definitely. And thanks again, everyone, for joining. You can see on the screen, if you wouldn't mind chatting in your name, organization, and since we are in the season, your Halloween costume. I chatted in my son's Halloween costume. Do I? Mm-hmm. Okay. And I'll turn my video on. Hi, everyone. Okay, so thanks again. Today we're in today's workshop, our October 2018 workshop. We're going to be talking about patient-family engagement and moving patient-family engagement from feedback to feed. Sorry. Sorry, I'm working with some new technology for myself here at our Long Beach office. To start us off, our vision here at PFCC Partners is to reinvent the healthcare industry so that hospitals, healthcare organizations, and all stakeholders continuously partner with empowered patients and families as that true resource in the co-design of programs, policies, and quality improvement activities. And so we're going to be talking about how to move patient-family advisors and patients' families upstream in some of that co-design and quality improvement processes. Thank you again for participating. Lindsay Bourne here, and you'll see Libby in just a minute when I pass the presentation off to her. And as a reminder, our conference is coming up. Registration is open. You can find more registration information on our website at pfccpartners.com/annual conference. Our conference will be held here in, around here in Los Angeles, California on February 4th in 2019. So we hope to see you all there. Again, you can find more information and registration information on our website. So getting us started in our workshop today, here are the topics that we're going to cover. We're going to talk about the difference between feedback and feed and identifying some strategies to move advisors upstream to feed co-design and improvement at, in healthcare. We're going to talk a little bit about the role of advisors and also learn how other organizations are partnering with advisors, specifically through the Patient Family Advisor Network. And then we're going to wrap up and look at some values of the continuous improvement approach to advisor engagement. And at PFCC Partners, that's really how we approach patient-family engagement, is in a continuous improvement or quality improvement approach. We understand that engaging patients and families is very different for each organization. And really looking at your organization and customizing how you engage patients and families that really supports the strategic goals of each organization. So quick Jeopardy question. You can chat in. What is the most underutilized resource in the healthcare environment? You guys are spot on. The patients and families, that is correct. Patients and families, patient-family advisors are the most underutilized resource in the healthcare environment. All of us here at PFCC Partners are patient-family advisors ourselves and use our voice as a resource to help inform and support quality improvement in healthcare across many different settings, and we'll be talking about some of those today. And to do a little bit of level setting before we get into some of the content, I'd like to start off with some definitions that we here at PFCC Partners commonly use. We talk a lot about person, family centered care, and that's really the noun or the goal that healthcare is trying to reach, that person family-centered care culture. But the actions that healthcare organizations are taking is patient-family engagement. That's actively engaging with patients and families. And like I said, we're really going to be talking about this quality improvement approach to engaging patients and families and the steps that are necessary to do that in a really authentic way that improves the strategic goals of your organization. But when you utilize that verb, when you have patient-family engagement, the outcome is that you'll see in healthcare organizations improved patient safety, improved experience, and really high-quality care. So to get into our topic for today's workshop, the difference between feedback versus feed. And so how we've seen it in the past with patient-family advisory councils and healthcare organizations really starting to raise the patient voice and listen to the patient and family population, we've seen a lot of feedback where the advisors, the project improvement teams, leadership, it's all kind of siloed, and the advisors are brought in when that team or leadership needs some feedback about a certain project that is already halfway through, or about a brochure that is completed, but now they want the patient-family advisor perspective to inform how this brochure or document looks. And so what we're really looking to do is move the advisors, patient-family voice upstream to be an integral part of project teams and improvement within the healthcare organization. So advisors truly feeding from the beginning, informing that improvement on these projects or process improvement teams or committees. So really bringing advisors in from the start. And as an example of that, because we also want to, in healthcare, tie a patient-family advisor perspective and informing improvement to the strategic goals of each organization, to really have that advisor perspective or patient-family perspective brought all the way from the beginning. So for example, this organization's strategic goal is to reduce readmissions. So they started a project to implement a community coalition of stakeholders that included advisors, patient-family advisors, to design a transition program. And so the output of that, having advisors informing that work from the beginning, is that those patient-family advisors, that work was informed from the patient perspective, and those advisors were able to point out challenges and gaps specific to that community in order to support improving the reduction of readmissions at this organization. So if the patient families were brought in much later, where you have the organization looking at transition, designing a transition program, they could have wasted a lot of time having not brought in the patient and family advisor perspective from the beginning. Because the patient and family was brought into the beginning, they were able to point out some of the challenges that they have had, and the team was able to make some of those improvements. So patient-family-centered care, the integration of it can happen in many different levels. Patient-family advisor engagement, like we've talked about, where we see a lot of feedback happening, are patient-family advisory councils who get brought into projects or looking at patient-facing documents once they're already completed. And what we're really looking to move towards is advisors integrated into improvement structures from the beginning. So moving them upstream in the process of improvement, and starting patient-family advisors when these project improvement teams are kind of first being built, and that structure is first being designed. We have a little car alarm going off, but that's okay. And to dive a little deeper into that, you can see here kind of the levels of engaging the patient voice in improvement. And at each of these different levels, there are different benefits to the organizations that utilize each of these methods. And you can also see that there is also a certain amount of resources and time that goes into each of these levels. And you can also kind of see that moving through these methods, we move from feedback to feeding improvement at the organization. So getting feedback from the patient family population through patient satisfaction surveys or focus groups. And then with a little more resource, developing patient family advisory councils, which is where you can, one, get feedback, or two, start to utilize the patient family advisors in that next step of informing project improvement teams. So integrating patient family advisors at the beginning of the development of these project improvement teams to really inform and provide that patient voice throughout the entire project. So some elements of impactful advisor efforts. Some of the low impact advisor elements that you can see here is is exactly what we're talking about, that first step of feedback. So lacking anchor to organizational priorities or the strategic plan of the organization, having a patient family advisor on staff just to say that you have a patient family advisor, and then the one glaring one, facilitators presenting information for feedback, which is important, but we're really looking to transition to a more high impact relationship that healthcare has with patient family advisors. Being really proactive and integrated across areas of the organization, and focusing on the structure of where for your organization is it going to make the most sense to integrate advisors to really raise the voice and have them inform improvement from the beginning. And there are also many levels to patient family advisor activities in these different points of engagement. There are some starting off points. You can see those in green where novice, new advisors can come in and really start to develop their skills as an advisor and how they're partnering with your organization. Those purple dots you can see requires a little more experience and a little more education for the advisors. Advisors brought into committees, safety initiatives, quality initiatives, and that's kind of where we're getting to that feed that we're talking about, advisors feeding the continuous improvement at these healthcare organizations. And then I think the kind of goal, which requires a lot more experience and even more additional training, is advisors truly feeding improvement from the top of the organization as part of that organizational board, having a say in new staff hires, and then presenting to faculty as well. And at this point, I'm going to pass it off to Libby Hoy. We're going to do a quick exchange here.
Move it, and the opposite. Thank you so much, Lindsay, for getting us started on this important topic and the important opportunity we have to, again, move patients and families upstream into a quality improvement approach to engagement. So this slide, I'm not convinced conveys exactly what I want it to, so I'm going to talk about it a little bit. And that's about what really the value of engagement. And the further upstream we bring advisors in, the higher the value. And that's what it's intended to demonstrate. I'm not sure that I hit the mark with that. But anyway, and as we're thinking about upstream, what is really upstream? In that slide that Lindsay showed a few minutes ago about the transitions and that transition project, let's take that for an example. If we might have an organization or a community collaborative who designs a transition, they've got the community pharmacist in the room, they've got the physicians in the room, they've got the case managers from the hospital in the room, they've got, you know, a really comprehensive group of stakeholders who are examining transitions. And then they all share their struggles and that perspective of struggle with what the issues are around transition, right? And then they might design a program. They design a transitions program that they think will really be beneficial to the patient and family. They want that to be the end outcome. And so somewhere in that, after it's been designed, they may take it to the advisory council that's at that organization. And the advisory council may be able to say, but wait, we're struggling over here. So what if we took the opportunity to bring the patient and the family to the community collaborative, and we brought that person in to help identify what the problems were, so that we as a team are not working on the wrong problem or working on only part of the problem, but we're working on the actual problem as identified by the entire spectrum. And that's the value of moving patients and families upstream. So what are some of those things we know are really helpful with that? Number one, that it feeds a strategic priority, and Lindsay mentioned that as well. So sometimes we see organizations develop an advisory program or a council with the best of intentions to really listen to their patient-family voice, to understand the patient experience. Really great and important work. But when the organization identifies the strategic priorities and then asks the patients, what do you feel would improve our experience? What happens? May or may not have alignment, right? What do we know about health systems? They move forward with resources and staff time and finances into the priorities that they've already set, right? So a great place to start is with the established strategic priorities. Now, that you would say that conflicts with what I just said, but what I recognize is the evolution of advisory efforts. And so if we can bring in advisors to feed, right, the strategic priorities that have been established, we know that that will organically move into those advisors in future identifying those strategic priorities. Make sense? All right, that was a rhetorical question. Of course it does. So what else is needed? Preparation of the team and the advisor, right? This whole set of readiness to partner. That's a really critical piece, and we're going to get to that in just a few minutes. That they're brought in at the beginning of the project. Oh, we had a duplication. And that there are dedicated resources to this partnership. So I have been an advisor for since the mid-90s, way before we had any credibility to be this far upstream. But the field has really evolved over time, and one of the evolutionary pieces that we're moving to is to consider who is leading the PFE efforts in a given organization and what staff member is holding that information. Now, I'm not going to tell you that there's one job title that's the right person for that. Well, in a perfect world, it would be the CEO. But anyway, it's not always going to be the director of nursing. It's not always going to be the patient experience director. Maybe we don't have one. Maybe we're talking about a quality improvement organization that doesn't have a nursing director or a patient experience director. Maybe it's a quality director. Maybe it's a safety director. Maybe it's a job title I'm not aware of. That's okay. It's where does it match with the organization's time and resources. But more and more as the field evolves, this is going to require that intentional dedication of resources and time, and that prickly pear budget. This is a prickly pear that, frankly, I've wanted to stay away from since I started with advisors, because I see it from so many different angles, but this is not something that we can any longer sort of ignore. And I can let you know that we here at PFCC Partners are supporting a compensation work group who's really working to do an environmental scan, understand the problem, understand all of those influences. But in order for us to really achieve the goal of hardwiring patient-family engagement in our health system, we're going to have to look at budgets, because it's not always going to be a volunteer activity. We heard very profoundly from one of our advisory colleagues, Desiree Bradley, that Collins Badley, that volunteerism in and of it by itself is privilege. And so how are we to accurately reflect the population of the country if we're not taking that into account? So just a few things to think about there. All right. So what are some of the activities that we might involve advisors in early on, in the midstream, and then in late? Number one, defining the priorities or defining the problem that you're addressing. Really getting their perspective to inform that. And notice I say the word inform, and I choose that one really carefully because it's not for us as patient family advisors to come in and tell you what to do or what the priority is. It's, again, another piece of the pie, another perspective to inform, just as all the other prospective stakeholders are informing. And then project design. How are you going to address it? Maybe that's a lean team and you're going to design the aim statements together, or maybe that's a quality improvement project that's going to go out regionally, and you're asking your advisors to help you design an improvement project that's really going to get there. And then maybe in the middle, we move to the project team convenes. And this is where I think a lot of organizations are thinking about engaging advisors, right? They've defined the priority, they know how they're going to address it, and they're bringing the advisors in. And this isn't, you know, again, this is all incredibly valuable. We're just really trying to think about moving advisors into the feed of our project. So then they might help you with implementation. So at a health system, they may help you to roll out a hand washing initiative, or, God, I hope we're not still doing those. Anyway, or something, a sepsis awareness program. Maybe they really help you move those out. And then later in the project, they're helping you to evaluate the early results and see what are the opportunities to improve on this project, to improve the outcomes with the project. They also would be involved in dissemination. So with research teams, we've had research teams actually engage us in authoring the papers and the articles that get published on it, and spreading. What an awesome opportunity to engage your advisors in disseminating what you've learned and how you've improved to the patient population overall of your organization. So I keep talking about advisor, and what is this advisory role? We have a longer definition on the website, and I'd encourage you to look at that if that's helpful to you. Stephen Hoy, part of our PFCC partner staff, kind of coined this, shortened it down, and said it's really people utilizing their lived experience to improve healthcare. So what do I know about healthcare? I know what I have received. I know what I have, the boys have received as a caregiver. That's my expertise. And so that has value to our improvement. And the further upstream we engage that value, the more benefit that we get. So what you see here in the triangle are the core competencies of effective advisors. And these core competencies were developed by the PFA network, which is a network of patient family advisors for patient family advisors. And together, through focus groups and surveys, we said, what do you guys use? What are those skill sets that you use in your advisor role when you're being most effective? And so we came up with the ability to establish partnerships, the ability to be constructively collaborative, solution-focused. Most importantly, and maybe you've heard me say this before, my biggest responsibility in all of this work is to be a representative voice. But does that mean that I can represent my Latino families in my community who are second language learners? No, I can't represent that experience. But what I can do is make sure that I've employed the other core competencies so that I'm always making space for every voice to be heard. And then finally, to be a teachable spirit. And again, acknowledging that there's a whole lot that I don't know about running a healthcare system or providing clinical care. There's a lot I don't know about quality improvement even. But there's a whole lot that I know about being a patient and a family caregiver in my local hospital and health system, in my region, in my state, and in my country. When we approach it that way And we see that in that reciprocal relationship Lindsay referred to, and our clinicians are seeing that, yeah, you know what, there's a lot I know about providing clinical care, but there may be something I don't know about receiving care in this system. We really hit that teachable spirit and hit that high value. So we talked about preparation as being a key, and we feel very strongly that preparation happens with both the receiving team, if you will, for the patient family advisors, as well as for the advisors. And so how do we approach those preparation pieces? Are they the same? Are they different? There's some common things that need to be addressed, but there's also some really unique needs in each group. So how do we get them all coming together with a vision statement? I am such a proponent of vision statements because it becomes the North Star that these two different, or even more maybe, perspectives can all come together on, right? So we're all going to agree that we're going to reduce sepsis mortality in our community. We're going to agree on that, right? So what do I need as an advisor? I need to understand the project. I need to understand who's at the table. Why do we have a pharmacist at the table? What is this QIO person? What do they do? I need to understand the roles of each of those. I need to be rooted again in my advisory role. What is it that I am there to do and perspective to provide? What's expected of me in that role? And where are my boundaries? Where am I not to be, right? Where am I, you know, maybe it's policy. Maybe I have a passion for policy, but in this particular team, policy is not on the table. So where are my lanes and the structure? What does the team need to know? They need to know why. Why are we bringing in patients and families? This is still a newer way to approach our work, and we need to acknowledge that with people. In fact, I really like to give teams who have not experienced working with advisors the opportunity to express their concerns so that we can put those on the table, put the elephant in the room, and have a really transparent conversation about their concerns. And talk through them. And oftentimes I find in that conversation, just acknowledging their concerns allays that anxiety a little bit. Second, my other strategy for that is to, if I've got some really anxious folks about doing it, we'll put that infrastructure in place. It's very helpful for the team to understand how the advisor is going to be prepared so that they're not imagining. I had a CEO one time tell me, so we're just going to walk into the ICU and grab caregivers out of there and put them on a board? No, we're going to do a whole lot more intentionality and preparation. And so I think staff members even knowing that is a really nice strategy for reducing their anxiety. And the other, if all else fails, I always go with a time limited. If you'll commit to really trying this for 3 months, we'll check back, we'll evaluate, we'll see if this is working for you. And I've not had the experience in the almost 5 years that I've been doing this, that a team has come back to me to say, you're right, or you were wrong, this was a terrible idea and we're not doing it. Give people a time limited if it feels a little bit more comfortable. Again, everybody's on the same page with the structure for the endeavor. I think that's really helpful as well. So I wanted to share some examples with you all about partnering across settings. And I'm going to tell you that all of these examples come from our experience at PSCC Partners in collaborating with some wonderful organizations and very innovative teams to bring forward patient-family engagement. And I wanted to do this because so often we think of the health center and we think of the traditional hospital system or ambulatory system or where care is really given. And there's the whole body of engagement work that happens within the care relationship, really critically important. But what we're talking about today is that advisor role and that partnership for designing our health system overall. So I wanted to sort of expand the thinking by sharing our experiences in engaging patients and families in a variety of different organizations. So let's start with the health system. So in our experience in supporting the implementation of a broad advisory program at Sutter Health System in Northern California, we were able to support them again in developing patient family advisory councils across their system at most of their affiliates. I think they're somewhere around 33, and Morgan, if you're on, go ahead and type in the right numbers, but I think there's somewhere just over 30 advisory programs in affiliates. They've got advisors on improvement teams all the way up to the top level of their sort of their excellence academy where quality improvement happens. They've got advisors on organizational committees, their quality committee, their patient experience committees, and others. So that system started sort of at the top, right? So they've got a corporate-wide initiative or strategic goal to implement engagement. That came down, and so again, you're going up to the very top. And then that gets modeled and implemented and happening throughout the entire system. So that's what's possible in a healthcare system. I think that's probably the most common example. So I apologize for that. So then we had this amazing opportunity to work in a CMS program, and I'm just going to give a little bit of background real quick right there. So Center for Medicaid Medicare Services, or CMS, runs a number of different quality improvement programs. Some of you may be working in, for instance, the Transforming Clinical Practice initiatives, where you're working to improve the care in the ambulatory space or the outpatient space. Some may be working in the Hospital Innovation Improvement Networks, or the HIN Works, Partnership for Patients. And that's, again, targeting the hospitals across the country to improve the safety. That's a particular safety goal. But one of the ways that in that project, one of the strategies is patient and family engagement in those safety improvements. And so CMS has been and funded a number of these quality improvement. And why? Because they're the largest payer in the country of healthcare. And so it's very important for them to be spending those dollars wisely and also in consistent and continuous quality improvement. So we had this opportunity to work in the Quality Improvement Organization, or the QIOs, the Quality Improvement Network, Quality Improvement Organization. CMS loves them some acronyms. And so we've had this amazing opportunity to work with the QIOs. So we were brought in from to the National Coordinating Center for QIOs, and we thought about, how do we do this engagement? This engagement is different. These quality improvement organizations are not touching patients directly. They're touching providers, and they're working through provider communities to implement the quality improvements, the safety improvements, and the like. So it was a little bit different than going to a health system. And so we had to think about that. And what we decided to do was work from top down, bring advisors all the way upstream to the National Coordinating Center. So how do we have advisors engage in that work, which is even then more removed, because they're not working with the provider group, they're working with the 50 QIOs. And what did we do? We had to think about and take all of our past knowledge of what effective advisory programs look like, and we started an advisory program for the National Coordinating Center itself. From there, we rolled out to all of the QINs and then to the QIOs. And so we had a strategy for implementing, but part of that strategy was a continuous learning. And right off the bat, when we started with the Gateways Collaborative within the QIOs, we were learning, because the QIOs representatives knew their work better than we could ever hope to know. These are our quality improvement professionals. They had been in this space for a long time, and so it was that continuous feed of how can we improve even this effort that we're embarking on together. So that now, where are we? We're about 4.5 years later. We went from a very little bit of engagement, none at the national level, to a national BFACT. We've got over 25 advisory councils, beneficiary family advisory councils, feeding the QIOs. The advisors are on task teams directly. They're involved in planning and presenting Learning Action Network events, which are their method for spreading what we've learned. And so we've really seen by moving upstream to the very top that we've been able to both learn a lot about how to do this engagement work at that level, but also to really spread it. Oh, I lost my... Great. So next we have the measurement team. So in quality improvement, we know that from CMS, we get measurements, right? Everybody's reporting on measurements. All your data goes to measurements. They're very important, obviously, to knowing what we're trying to improve and knowing if we're actually meeting our goals. So we now are engaging patients and families directly onto technical expert panels that are monitoring the measurement development. They're also getting to be part of deciding, so making priorities around measurements. What do we measure? They're involved with CMS at different levels, and I think I left off. And also National Quality Forum. National Quality Forum doesn't touch patients and families, except that they do, because they they endorse the measures that healthcare organizations report on. And so having patients and families even at that level is moving us way upstream to really engaging and getting the value out of that engagement. And then research. So I got to tell you, when Sue Sheridan, a wonderful colleague who was the original patient family engagement director, person, lead, I don't know what the exact title was, for Patient-Centered Outcomes Research Institute, she came to me about, well, in 2010 when they were launching and said, this is what we're doing. And I said, Sue, that makes no sense. You have a background, you have some advanced degrees. I'm just a patient family member. I am going to have no influence over research teams. I don't get it. And then I had an experience where I got to sit down with the leading researcher in mitochondrial function, which is what the chronic condition my boys live with. And I thought, oh, he's going to answer all my questions and I'm going to get it. I'm going to understand how to take care of the boys better so they have a better quality of life. You can imagine within 30 seconds we went whoop, and we were just out of alignment on our conversation. I didn't understand. He was telling me about how the molecule breaks down and the respiratory chain works. And I was like, just tell me how to improve their lung function, because that would be the best quality improvement that they could have. And so that's the opportunity that we as patients and families have to inform research, especially patient-centered outcomes research. And I thank PCORI so much for the vision and oversight that they have had and the movement they've created about engaging patients and families into research. So I've listed just a few up here that we're currently involved in. The Aging Initiative. This is a National Institute of Aging, so an NIH-funded research project. Now we're moving beyond PCORI, really more deeply into the research world to, again, identify what are the priorities, what do we need to be studying. And in the Aging Initiative, they have a Young Scholars Program. So how can we influence young researchers coming up to start with engagement from the get-go, talk about moving upstream, right? The GEAR Initiative in geriatric emergency care and how they're moving those guidelines forward and what we really need to understand about how it is when we bring our older parents with dementia into the emergency room and what needs to happen there. So again, really engaging patients and families at the outset. I've mentioned PCORI, but I wanted to share with you one experience that we had with the Patient Priority Care Research Agenda. This was a PCORI Engagement Award that we received. I was the co-PI on it, along with Dr. Carolyn Blom and Dr. Mike Rich. And together, I have to tell you, this is one of the most biggest learning experiences I've ever had in developing the engagement community. So we didn't want just Libby Hoy's voice in leading this project or influencing this project. we had as a co-investigator, so we had the three of us as that smallest circle, concentric circles. Then we had a planning committee that had about a third patient family advisors, along with other stakeholders and researchers that could tell us if we were moving in the right direction and what other directions that we should go. Then we had stakeholders, and we had 2 meetings where we brought stakeholders in, stakeholders being payers, researchers, clinicians, and patients and families, into these multi-stakeholder meetings where together, through interactive meeting planning, we elicited the group's priorities for research. So where are those gaps in what our understanding is about how to move patient priority care into geriatrics? And so through that, we had all of these folks, about 60 of them at each meeting, to help co-design the priorities for the project. And then we brought that to the broader community through open webinars to say, this is what we've come up with. Give us your feedback. Let us know where we are, where this resonates with you. And we had about 250 folks on that webinar that were able to give us that feedback. And so I wanted to share this because to me, it was in essence feed to feedback. The blue circle out to the red circle was feed to feedback. And I want to drive home the point that one is not more important than the other. It's just if we think of it as a continuum and embrace all of those opportunities, we really get this rich discussion back. And then finally, the work groups. Now, this is a little bit more unique. So what are work groups? Everybody has work groups. These are work groups that are hosted through the Patient Family Advisor Network, which is a program of PFCC partners. In that network, we have over 600 advisors. So those are folks like myself, Lindsay and Stephen, who are currently partnering with healthcare organizations and systems to provide that patient-family perspective. So from that, they're the same group that helped us to create the core competencies. From that group, we have virtual meetings and we have an online community, and we've bubbled up these issues that we think are important as we move deeper into engagement and move closer to being a continuous feed for engagement. One is the National HIT PFAC. So that was actually came from a larger summit meeting we had with advisors where we felt like access was a real problem. Access to our health records particularly were a real problem. And so we were fortunate enough to create a wonderful partnership with OpenNotes, who funds the Health IT PFAC. And that gives us an opportunity to learn about the patient's experience with both OpenNotes, but more broadly, patient portals. I forgot that word. That was so weird. Okay. And so that's just one effort. A qualitative work group, another area we found that there was a bit of a gap was in telling the stories in a way that could be supportive of further research and understanding of the patient story overall and the value. And then finally, the compensation work group. I told you guys I didn't want to touch that one with a 10-foot pole, but this is really important, and this is limiting because we haven't addressed it in a robust way. It's sort of limiting our ability to get to those diverse representations, the diverse representation we need in our engagement efforts. So that's just another way. In all of those advisory-driven work groups, we have professionals at our side informing us. We've got NQF sitting at the table on the compensation work group with us. And so this is how we're looking at engagement across settings. This is how we're not just looking at it, but how we're actively involved. So we can't ignore the fact that there's some challenges to engagement, and certainly to the type of engagement that providing a feed definitely incurs. One is speaking the same language. And I think this is, needs no explanation, right? When I first started working with the Quinn QIOs, and they had this entire language of quality improvement that I didn't know, and a whole other language of acronyms that I certainly didn't know, and now I find myself speaking. There was a coming together. There was a meeting in the middle of our NCC team really informing me and us figuring out what are those terms that have to stay as they are because they indicate that particular quality process, and how do we support the understanding of those for advisors, and also what are those terms that we could demystify and use simpler language with. So it was you know, together we figured those things out. Budgeting for engagement, you know, as I said, we're working on this. The environmental scan we just completed was very informational in terms of some of the different models, I guess, for compensation, for lack of a better word. And we'll be putting out some more information on this. But I think what we've learned thus far, both through the environmental scan and a survey that we did with the PFA network, what we've learned so far is it is not going to be a one-size-fits-all. It's going to be a very, have to have some variation to it. Another challenge is that this is a new way to do work. This is a new way for folks who are not in direct patient care to think about engagement and to think about how the voice and the perspective of the patient and family may be able to, excuse me, may be able to inform the way they do improvement. I think this is the other benefit of taking a quality improvement approach to this, is that quality improvement folks by nature are innovators. And so the new work, the new thinking and the new work really is not such a threat. So I'm starting to think we should be encouraging our health systems who are engaging advisors through the patient experience work to really tap into the quality innovators they have within their organization. And then the fact that it's new work. And a lot of, again, organizations, I don't know anybody in healthcare who only has one job title anymore. I don't know anybody in healthcare who's sitting around with a lot of spare time. Everybody is dealing with competing priorities. And so we want to shift the thinking from patient-family engagement as being another activity that they have to do to patient-family engagement being a tool in their toolbox, a strategy they can use to be very effective, to be very efficient in their improvement efforts. And I think that efficiency is huge. So we worked with a healthcare organization who designed their patient portal and then brought it to their advisory council and said, what do you guys think of this? And they said, oh my God, this part's great. This part I'll never use. This part doesn't make sense. If you just tweaked this a little bit, boy, that would really be powerful for us. That was a rough lesson for that organization to learn, because then what do? They've got a choice of, well, this is great information, but we already designed it, so we're just going to ignore it. Good luck getting those advisors involved again. Or what this organization did very bravely is found the thousands of dollars to go back and redesign their patient portal to include some of the advisors' engagement. So the efficiency of moving them upstream and the opportunity costs of not doing so are very high. And so we really encourage that it's not new work, it's new way to do the work you're already doing wherever you're working in healthcare. So what we have found and what we have implemented here at PFCC Partners, we do a lot of matchmaking for advisors and getting involved in engagement efforts across the country. And what we found is it's really important to evaluate those efforts. And here's the kicker. It's really important to evaluate from the team and from the advisor. So I know, I can tell you that I've worked on a few teams where the word token might have applied. And I've worked on teams where I'm really highly engaged. And so if you only ask the team how that engagement was, you'll get that perspective. And I can tell you that on one particular one, that team would probably rate the engagement really high. But if you would ask me about it, I would tell you that it was very limited. I had very limited opportunity. I was reviewing things, and sometimes those things couldn't even be changed. So I don't know why I was reviewing them. And so I would have rated it really differently. I think we have to look at engagement and evaluate it from all perspectives, because that's the relationship, that's the value. And the more we evaluate, of course, you all taught me this, you all being healthcare and the need for data, the more we evaluate, the more we know where our sticking points are, and the more we can design and improve. Again, continuous improvement. So we recognize, again, that this is a new way to do work, that the competing priorities and conflicting messages that are out there make this a little tough. Patient and family engagement can be a little tough. But what we want to really encourage you to do is to move forward from wherever you are. I don't believe there's a bad starting point for patient-family engagement. Don't wait until the perfect setting, because I don't know about you, but I don't see a lot of perfect settings out there. And so it's an opportunity to start where you are, take the first step, have the first conversation if you haven't started. If you have started, it's the time to challenge yourself to move those engagement practices even further upstream. Board of directors, priority setting, identifying the problem. Whatever that next step is, take that next step upstream for your engagement so that you and your team can get more value out of it. So that's what we wanted to share with you today. It looks like we have about 4 minutes left. If anybody has any questions, I'd be happy to take them. And you're welcome to pull yourself off mute, or Stephen, if you can unmute all. Or maybe I can. Oh, I unmuted all. Now you're all unmuted. If you'd like to ask a question, either chat it in or feel free to speak up. We also welcome suggestions for how we can improve our presentations to you.
Libby,
Yes.
I got really hung up today. Is this being recorded that I can watch or view again?
It is indeed, yes.
Okay, thank you.
Uh-huh.
This is Debbie. I actually work at a hospital, and you are so articulate that I would love to see if you would be willing to, and we're just starting this journey and trying to figure out how we can involve patient family advisors. I would love it if you'd be willing to even write an article, or if you have a past article you'd be willing to share that we could put in a organizational newsletter just to start generating awareness and excitement for engaging patient family advisors.
Absolutely, we'd love to help. Just you can either email me at the email on the screen or call the office, and we'd be delighted.
Great, thanks.
Where are you from, Debbie?
Seattle.
Oh, great. Okay. One of our social media coordinator is in Seattle as well.
Ah, yep, Tech Center.
Yes. Any other questions or thoughts? Does that resonate?
Libby, just one comment. This is Harvey Hellerstein here.
Hi.
Being with an established PFAC and currently with a PFAC trying to get started. When I say trying, I was invited to participate in this current PFAC last December, and the first meeting happened in September. So in previous one, it was already established. And there was a mission statement, there were bylaws as far as how long people could serve on the PFAC, and very well organized. That was in Philadelphia, Fox Chase Cancer Center, currently in New Jersey, and Robert Wood Johnson system of hospitals. Each community hospital is trying to start a PFAC, and I got an email the other day from one of the docs, and he said basically, we're trying to get this thing rolling, He said, let's compare notes once I prepare my presentation for the next meeting of what I learned at PFAC boot camp. So it does make a big difference where you enter as an
Yeah,
advisor.
it does. Absolutely. Well, thank you. I appreciate you sharing your experience. Any final questions? All right. Well, I think that brings us to the top of the hour. I very much appreciate all of you joining us today, and you know where to find us. I see in the chat box somebody's asking about the recording. The recording is posted to the website about a week after. So if you'll give us that time. All right. Enjoy your afternoon, everybody. Enjoy your day, and go Dodgers.